Buenas tardes, boa tarde, good afternoon, everyone. Good morning for Dr. Ames, and and good night, good evening for Dr. Pizones. We welcome everyone and thank you all for joining. This is a very special webinar that we have today. We have visits. We even put suits today just to honor our speakers today. So we have Dr. Chris Ames, that many of you know well, from UCSF in San Francisco, and Dr. Javier Pizones from Hospital La Paz in Madrid, that you may know and you're gonna get to know today. This is a very interesting subject. Artificial intelligence is affecting many aspects of our lives, and it's gonna do much more in the future to come. And we want these two experienced surgeons to share with you guys in Latin America what's going on the spine field, that you're gonna see these changes coming into your office, UR, etc. So without further ado, I'm gonna give the mic and the screen to Dr. Ames, and you can go ahead and start presentation, Dr. Ames.
Okay, I think you have to give up your screen to me.
I did. Yeah.
Okay. No, I don't see my talk. Oh, here we go. Sorry. Well, welcome everyone. Sorry, I was having a little bit of a slide issue there. I really appreciate Medtronic and sponsoring this webinar on artificial intelligence, which, as most of you know, has been very near and dear to me in terms of our research strategy over the last several years. We've been working diligently in the International Spine Study Group and the European Group, and today with Dr. Pizones, we have both viewpoints represented as to where we're going with artificial intelligence in the field of adult deformity surgery. I usually like to start out by asking really kind of a far-reaching question, which is, if you were sitting down to try to make adult deformity surgery safer for patients and better for surgeons, what ideas do you have that you think would really improve the quality of the care and the outcomes in these patients? And do you think it would be a new implant, for example? Maybe you could ask yourself an honest question about whether you really think that a new screw design or a new screw head design would really subserve that purpose of making the surgery safer, more efficient, and better. Or perhaps we need more of a broad perspective, and maybe to take a step back and look at overall what we're trying to accomplish with innovation. One way that you might envision us being able to do this is to say, okay, well, maybe spine surgeons could just get better. But if we take an honest look at that, do we really think that the next generation of surgeons are going to be better than, for example, Dr. Lenke? And actually, you can use predictive modeling to estimate the upper limits of human performance. They've done this in the Olympics, trying to estimate 100-meter dashes based upon the biomechanics of the human body and what they feel will be the upper bounds of human power and work and all these physics concepts. And they're actually, fairly accurate. But maybe the next generation of surgeons is not going to be technically better than our best surgeons today. And maybe we need to look at technologies that will augment human performance, and not just physical performance, such as robotics, but actually human mental performance and human intelligence in selecting the appropriate patients. One of the most interesting comparisons is actually from the game of chess. And this is one of the first instances where we really saw the power of machine learning. And many years ago, Garry Kasparov was defeated by the IBM computer Deep Blue. And then over the subsequent years, the artificial intelligence chess programs have actually gotten quite a bit better. And one of the main programs was this program Stockfish 8, which could make 80 million moves a second and understood the entire history of chess. And this was the reigning chess champion for many years, and it digested all the history of all the moves of the great masters and had a very fast processing speed and reigned supreme for many years. However, then more recently, Google developed a program called AlphaZero. AlphaZero can't make anywhere near the number of move calculations that Stockfish 8 can do, and was actually given no history of any of the moves in chess. It was merely told, this is how you win at chess, and then the computer played against itself and taught itself very rapidly how to beat the reigning chess champion computer program. And can you guys guess in your own minds how long it took this program AlphaZero, using only machine learning, to beat the reigning chess champion Stockfish 8, 28 games to 0? It taught itself how to do that in only 4 hours. And what this tells me is that if we can build the ultimate algorithms to analyze our patients and these complex multivariate analyses that we all sort of do using human intelligence now to predict risk and outcome, that this may be a way to augment our intelligence in predicting what's best for our patients and to make the surgeries safer. AI has been exploding all over healthcare in the last several years. This is just a summary slide of the FDA approvals. This is US based, obviously, for artificial intelligence algorithms that are now approved for use in caring for patients. Many of these are in histology. Some of these are in radiology, but increasingly we're seeing some use in diabetes and other aspects of trying to augment human care of these patients. It's not merely imaging interpretation, for example. Increasingly, we're moving toward clinical situation interpretation to augment our decision-making. All across the US and Europe, we're seeing an increase in our aging population. We have 53 million people over 65 in the US, 80 million people over 65 by 2050. We have a high prevalence of spinal deformity. And in the US, that gives us right now about 32 million people with some type of adult spinal deformity. Obviously, not all these patients are going to undergo operative treatment, but many of those patients will at least be processed through the spine deformity clinics and trying to figure out what's best for them. And this represents a huge financial drain on the healthcare system, even in a country with, at least previously, before all the COVID hit and all that, really a pretty significant healthcare budget. And we see an increase in the number of these cases, a tremendous over 150% increase in adult deformity procedures compared to AIS procedures. Total healthcare cost in the US, 3.5 trillion. And then we add into that our more recent situation with COVID and the economic pressures of COVID. And you can see significant amount of expenditure, 800 billion a year in orthopedic disease, and realize that's up against expenditures for dementia care, for cardiothoracic care, and for other aspects of care of the aging population. And that leaves us a small bucket that we can spend on spinal deformity care. And with inflation and increasing healthcare costs, it's becoming more difficult all the time to protect that budget that we have to spend on this patient population that we know that we can benefit. So even in the US, which has in the past been very protected from pressures related to healthcare spending, we know that a storm is coming our way, and we're not going to be able to just broadly apply expensive treatments to all these patients in the future. And up until a few years ago, we didn't have good tools to augment our own human intelligence about how to do this in the best possible way. One approach was popularized by one of my colleagues in Seattle, actually trained with us many years ago, Raj Sethi, who developed essentially a tumor board type of approach to deciding which adult deformity patients we should operate on. And the way the human mind works, it tends to mostly focus on risk. So essentially, this multidisciplinary panel would look at the patients and try to figure out, which of these patients was going to have the highest risk of surgery. And if you only eliminated those patients that were more likely to have complication, the thought was that these patients are going to do better, that this is a better choice for this population of patients in terms of who to operate on. But there's a huge logical problem with selecting patients based on risk. Actually, the older patients that are more likely to have complications are actually the same patients that are likely to have the greatest magnitude of clinical benefit from the intervention. So simply filtering these patients based on risk probably doesn't make sense. And again, human intelligence is not the best at predicting outcome and benefit. We're better at predicting risk, like an 80-year-old patient with heart disease, for example. Our minds can kind of wrap themselves around that. So our group, the International Spine Study Group and the European Spine Study Group, and specifically some of our colleagues to do with these projects, Dr. Pizones and Dr. Police and Miguel Serra, we started trying to figure out, what if we took a big data approach to the patient? And rather than painting the patient with a few data points like age and comorbidity, what if we looked at hundreds of different data points per patient? What could we do with the power of that information? So the first thing we did was to come up with a frailty score, which essentially was a measure across about 40 different data points of a patient's physiologic substrate, painting a deeper picture of what that patient's susceptibility to the risks of surgery might be. And this we did in our existing database. We went back and we pulled these data points out, spanning multiple systems such as psychiatric issue, physical issue, neurologic, balance issues, continence issues. And we came up with a 40-point frailty score that correlated very well to patients' risk of major complication. You can see it doesn't just correlate to one risk, but PJK, pseudoarthrosis, bone health, all seem to be intimately related to this concept of frailty. This is our frailty system, and at my institution, we've essentially made this a predictive review of systems, where we have incorporated this now into our medical record. And rather than doing a review of systems that doesn't educate the surgeon and really doesn't help the patient in terms of their decision-making, if we use frailty as our review of systems, we get actually useful information about how that patient's likely to do. So in my institution, this is how we work. We see the patient, we look at their x-rays, we calculate their frailty, and then in real time, this is what we get in our medical record. It tells us the patient's frailty score and what that patient's risk compared to a patient that's not frail, what complication rate that patient's likely to have, and how much longer that patient's likely to stay in the hospital. As we move forward, though, in collecting these data points, we've realized that we collect a lot of information on the patients, but when we look through our models, we realize that there's still a lot that we don't collect, and we call these unknown unknowns. So our ability to predict is really based upon how comprehensively we cover the patient. And as we cover them more, for example, with genetic information and physical strength information and gait information, we may be able to do better in terms of predicting the variability in their outcomes over time. And this is some of the work that we're doing in the future, and we can talk about it in the end. But realize our prediction ability right now depends on the data we collect, and some of those variables we might not even realize we should be collecting.
So we hear from you, okay?
At my institution, we now collect walking speed, we collect muscle bulk information.
Wow, you walk fast. Good, perfect.
We measure sit to stand times, and I'm not going to let this play out completely, but you get the idea. We've started to, while we simultaneously were making these risk calculators based upon information we collected in the past, we're simultaneously trying to make these calculators even better by collecting new information that will impact other aspects of health that we weren't collecting in the past. We also look at mental frailty. We do dementia screening. We look at pain medication usage, and many of these patients have catastrophizing aspects to their personality. And at my institution, we're even doing personality classification, where we're looking at what is their Myers-Briggs personality type and whether or not this may affect the patient's satisfaction with our care, whether it might in fact impact their medical legal risk. And furthermore, and I won't go into all the details on this slide, we're also looking at telomere length, which is a measure of a patient's genetic age. And we think that this telomere length, we have some early evidence that telomere length may actually correlate better to risk of complication than a patient's chronological age. And now I'm going to talk to you about the data that we used in the past to collect the risk calculators that we now use. This is a little bit of the future in terms of, where we're going. One of the things we realized once we created the frailty index was we also wanted to datafy the operation. We realized that we have the data on the patient, but you can't take that data and put it through a calculator unless you have a way to datafy the actual operation. We need not to have, a T10 to pelvis PSO. That has to be a numerical value if you want to correlate that to, for example, blood loss and operative time, if you want to talk to the anesthesiologist about that. So we developed an invasiveness score that correlates well to blood loss and operative time, and we now use that at my institution to talk to anesthesia about what would be the likely transfusion requirements on that patient. How long is the operation going to take, so they can plan extubation and those sorts of things. So that was our initial approach. We made scoring systems based upon physiology. We made scoring systems based upon the procedure. We started to look forward in terms of other variables we could collect. But we realized that we might still be missing something, and that's the interaction of all these different variables together. And that's really where we moved more solidly into the field of predictive modeling and artificial intelligence, where you look at the patient, you look at the operation, you look at modifiers of the operation, you look at when the operation's done, who does the operation, and all these things may be able to help us increase our accuracy in predicting risk and outcome in these patients. Actually, there have been several studies that have shown that in general, surgeons do very poorly at predicting patients that are likely to do well after some orthopedic operations, in terms of who's likely to have a significant clinical benefit. And much of this work has been done in general surgery. Some of it's been done in orthopedics, for example, with meniscal repair and that sort of thing. But when I present this around the world, I often will get a surgeon that will say, well, wait a minute, I know what's best for my patient. I don't want to be replaced by big data. But if you really take a hard look and you look at what's already been published, surgeons actually don't do that well, especially with integrating the outcome of their patient, how well they're likely to do. We do better at predicting risk. Even experienced surgeons in this study didn't do very well in predicting who was likely to improve after meniscal repair surgery, for example. So this all prompted us to come together, and I should mention, importantly now, since this is mainly directed at Latin America, our group combined with the European group has helped to deploy the Latin America ISSG, starting in Brazil and hopefully moving soon to Argentina and Chile and Mexico, to help to have additional databases that we can use to integrate into this worldwide collaboration. And last year, the group in Asia just came on board. So now we have registries and data repositories really across the world to help us in this effort. In the next 5 minutes before I finish up, I'll go over some of the early work that we've done in both groups, and then Dr. Pizones will talk and show you how these calculators are used. We have 17 sites, 35 surgeons now, just in US and Europe. And essentially we concentrated on several main areas. One was to say, could we make the informed consent for surgery active at the point of care and patient specific? So think for a second, how do you tell your patient how well they're likely to do with surgery right now and what their complication rate is likely to be? Well, if you're diligent, you would go to the ISSG or ESSG complication papers and say, well, on average, these patients had this complication rate. But if you want to be more precise, you can use the risk calculator, which has up to about 75% accuracy, and you can exactly place the patient in the context of every other patient in the database and say, this is you. This is your complication rate at 2 days after surgery, at 1 year after surgery, at 2 years after surgery. And you can place this patient in the context of every other patient in the database and say, this is your likely complication profile over time. And this was based on a predictive model that Farhan Police published and presented at the SRS. And you can see we can predict this before surgery with about 76% accuracy. All the way up after discharge, we get even higher accuracy, up to 80%. And the discharge time point is important because if we can identify patients at risk of reoperation and readmission, we can generate other mechanisms in place to keep that patient out of the emergency room. Like, for example, a fellow or a physician assistant will call the patient to make sure they're doing well if they're at risk for readmission. And these are quality metrics that we follow very closely in the US. One of the things that we realized very quickly was that a large part of what is causing complication in these patients or is correlating in complications are actually potentially modifiable risk factors. For example, how much a patient walks and what the patient's urinary continence status is, or what the patient's physical stamina is and general condition. And we realized that some of these may be able to benefit from a prehabilitation process. So at my center, we started a prehab study where we look at multiple domains of the patient's risk factors. And this is data and studies that are based off of the predictive modeling studies that we did, where we try to optimize the patient's physical function prior to surgery. We look at other aspects of the patient, such as pain management, psychiatry. Are they depressed? If they're depressed, we try to optimize their mood. And things like smoking cessation, bone mineral density, and nutrition. All of these things that we found were important from the predictive models and from that initial study on predictive modeling and risk. And we now take that back to the patient and see whether we can optimize them prior to surgery, looking across all these different domains. There also have been studies showing that risk calculators can improve risk assessment. So if you have the ability to predict risk, surgeons are able to take that information and use it in real time with the patient. So it seems like a tool that is going to be helpful to the patients. And I'll finish up with this. And this was what was lacking from the use of human intelligence. A patient, when in my experience, since we've been using these calculators, when you talk to them about the risk of surgery, most of them are so impaired that no matter what you tell them the risk is, they still want to have the surgery, especially the older patients who feel like they're nearly crippled and very disabled, which is a high proportion of our patients. But what they really want to know is surgery going to benefit them? They're going to take this risk on, but how much better are they going to be? So if you think for a moment, how do you quote right now to your patients how well they're likely to do after surgery? Well, maybe you look, again, at the best paper from ISSG or from ESSG, and you say, well, on average, patients did, this much better after surgery. Well, when we really dug into that, we found that only about 5% of patients in this combined database had what's called an average improvement, really within, a standard deviation of the average amount of clinical improvement. And patients had a widely heterogeneous clinical progression after surgery. And you can see from the graph just how varied these patients actually did. So we realized if we already were able to do risk, the second part of that was to predict how well patients were likely to do. And so based upon another AI-based calculator with 75 different variables, we found that we can predict with up to about 75–80% accuracy how patients are likely to do after surgery in their SRS-22, in their ODI, in their SF-36, and in their MCS scores. And we can predict this prior to surgery. And we can predict this with Operation A or with Operation B, et cetera. So we can use this in real time to assist in our decision making. And one of the interesting things we found, at least in the data looking at benchmark sites, so the best sites in Europe, best sites in US, we found that the surgeon in site, despite all the surgeons thinking that we made such a big difference, who did your surgery and where you had it done only accounted for about 1.8% of the variation in the outcome. And most of it was determined by aspects of the patient's baseline physical and disability status. And very importantly, and I'll finish with this comment, very importantly, we did not find that the sagittal profile of the patient, either preoperatively or postoperatively, resulted in or had a significant impact on how that patient did. And it was much more dependent on other factors related to the patient's baseline status and their baseline physiology, and was not directly related to the sagittal plane. And this was kind of another way that AI totally changed the way that we were thinking about these patients. So now I think I'll yield back the screen after that background, and we can see from Dr. Pizones how the calculators that we developed are used. And then at the end, I can take some additional questions. And if there's time, I'm happy to show a little bit more about our new adult deformity classification at the end that's based on some of this. But I want to show you guys now how the calculators are used. So Dr. Pizones, I'll turn it over to you.
Okay, one question before I start my presentation. With so many things that you have to do, so many tests you have to take the patient, physical, mentally, all the prompts. How many people are working with you actually in your office?
Yeah, I want to be clear, and that's a really good point. That is the one obstacle to adoption that we found with the collection of more and more data. Many of those studies, for example, our personality study and our gait studies and our genetic studies are just that right now. They're just studies. So not every patient is getting all of those things. If we focus purely on the calculator, we have, you may show this, we've developed a shorter version of the calculator that's a little bit faster. But still at my site, I dedicate someone entirely to using the risk calculator and handling the measurements that go into that calculator. So at my site, I have someone who enters all that data. And then when I see the patient, I have all that data laid out to show them their choice of surgery. And then we use a measurement service that actually in real time measures our x-rays. So we have the measurements done by a third-party company. They're available in real time in the clinic. And then we use those measurements to enter into the risk calculator along with the additional data fields that we enter. But still, it still requires really a dedicated person. And that could be, a clinic assistant, a research assistant. We're trying to make them as accurate as possible while still being as efficient as possible. But it's difficult.
Okay, thank you very much, Chris. So I'll go on with my talk.
There is one more question, Dr. Pizones, but you can leave your talk up. It's fine.
Okay.
It says, will you make this software available for the scientific community for calculating fragility and risk of complications?
Yes, for sure. And actually, there's nothing proprietary about our frailty score or our invasiveness score. These have all been published. And it clearly states what data fields you need to collect and what the cutoffs are for each stratification. So if you don't have the AI, you can use frailty and invasiveness to get a rough estimate of complication rate and blood loss. We still need the AI to do outcome. And this year, we published a decision tree analysis that can be used to roughly group patients into categories that will help you to predict outcome. And then in the future, we hope once we beta test this through the ISSG, ESSG, and maybe Asia and Latin America, once it's beta tested and we make it a little bit easier to use, we want to open this up to the spine community at large through the SRS and through the regional societies.
Yeah, just adding a little note to that and to something that you already said. There is a team in Brazil, led by Dr. Fogassa, Dr. Meneses, Dr. Marcon, and some others. They are translated into Portuguese, validating, making it approved by to collect data from patients and build these databases. And once it's ready, it's going to open to the Brazilian community first, and most likely to some other places in Latin America. So thank you very much, Dr. Ames and Dr. Pizones. Please go ahead.
Thank you. Thank you. First, before I start, I want to make the last question to Chris. How long ahead from surgery do you start with your pre-optimization of a patient? Because that takes long.
Yeah, it does. And it we generally have it at minimum a 3 to 6 month wait list. Thankfully for this, most of these surgeries are non-urgent. Exactly how long we wait depends upon what aspect of the pre-op optimization we need to really focus on. So, for example, if it's a simple amount of really general conditioning of the patient, well, that probably only requires maybe 3 months of physical therapy and maybe some nutritional, nutritional augmentation. If someone has depression, it may be that, that can be improved within, 6 weeks to 3 months. If someone has a significant bone density issue that we uncover prior to surgery, that may take a bit longer, and we might have to wait, 6 months or even longer sometimes to do the surgery on those patients. So really it depends on, what aspects of their physiology and their frailty that are potentially modifiable that we identify, how long we would then, wait to do the surgery. But at minimum, it's usually about 3 months.
Okay. Thank you. So what I'm going to cover in my topic right now is the practical way to put this tool and to cover artificial intelligence with our patients in clinics. My slides are in English, so we can all follow, but I've been asked to give my talk in Spanish, so I'll switch into Spanish for the talk, and then we'll go back to the questions in English. Así que lo que voy a contar es la experiencia que tenemos nosotros en Madrid sobre inteligencia artificial. Madrid es uno de los sites que participa en el ESG y, como muy bien ha dicho el doctor Ames, trabajamos conjuntos y hemos trabajado conjunto para realizar esta estrategia y esta herramienta. ¿Cómo tratábamos antes los pacientes? De manera habitual, es decir, esta, por ejemplo, es una paciente, 74 años, viene a nuestra consulta porque tiene dolor lumbar, tiene dolor irradiado por la pierna y se queja que tiene un bulto en la zona de la espalda y que va desequilibrada. Ya ha pasado el tratamiento conservador, le han hecho infiltraciones, ha tomado analgesia y, sin embargo, sigue con mucho dolor y con falta de función y busca algo más. Lo más corriente es que hagamos unas radiografías y tomemos una imagen de resonancia para ver cómo están sus discos. En las radiografías podemos ver perfectamente el equilibrio sagital y el equilibrio coronal de este paciente. En este caso teníamos una curva lumbar que se traducía en el plano sagital en una cifosis toracolumbar y, como vemos, ya estaba en retroversión, ya está compensando mecanismos de compensación para mantenerse equilibrada. Sacamos habitualmente también radiografías dinámicas para ver la flexibilidad de la curva y con ellas vemos que no hace falta gran cirugía aquí, no hacen falta osteotomías, es una curva flexible. Y con eso decidimos qué hacer con esta paciente. Sabemos que lo que lleva al paciente a la cirugía son fundamentalmente los síntomas, mucho más que la radiografía y las imágenes. Y también sabemos que los pacientes que no están contentos con su estado de salud se van a beneficiar de una cirugía mejor que de un tratamiento no quirúrgico, de un tratamiento conservador. También tenemos que tener en cuenta, y estos son datos del ISSG y del ESSG conjuntos, que el riesgo de complicaciones es alto en estos pacientes con deformidad del adulto, que puede ser rondando el 40% con un 20% de reintervenciones para solucionarlo. Bueno, pues con todo esto planeamos nuestra cirugía. En este caso decidimos hacer una fusión desde la mitad de la columna alrededor de T10, incluyendo la pelvis. Solo por detrás, no hicimos vía anterior, no pusimos caja y restauramos así el equilibrio coronal y el equilibrio sagital. Y esta es la manera que hemos tenido de tratar estos pacientes hasta hace poco. ¿Pero qué problemas hemos tenido? Que estos pacientes muchas veces nos dan sorpresas. Aunque nosotros pensamos que esto ha funcionado bien, vemos que a los 130 días esta paciente desarrolla una cifosis de unión proximal, una PJK. Y entonces decimos, Dios mío, ¿pero qué he hecho mal? Yo he calculado todo bien, he hecho bien mi análisis del paciente, he visto bien mi radiografía, he calculado bien los niveles, creo que lo he dejado en una buena plano sagital y sin embargo he tenido este desastre. Entonces, ¿qué otra herramienta puedo tener? ¿Qué me puede brindar ahora la ciencia para intentar mejorar y disminuir mi riesgo de complicaciones? Y aquí es donde sale el papel de, entre otras cosas, la inteligencia artificial. ¿Cómo funciona? Pues funciona de la siguiente manera. De manera lineal, el paciente hace una cirugía, se hace una cirugía sobre él y se mejoran los cuestionarios de salud. Pero no siempre esto es tan lineal. Muchas veces tenemos complicaciones entre medias y esas complicaciones afectarán a los resultados que obtenemos en estos pacientes. ¿Cómo podemos limitar estas complicaciones y con eso mejorar el resultado clínico de estos pacientes? Pues atendiendo a las dos primeras características, que es atendiendo a la característica del paciente y de la cantidad y tipo de cirugía que voy a hacer. Y entonces, a lo largo de estos últimos años, se han desarrollado unas herramientas que ya hemos visto en la charla del doctor Ames. Para evaluar al paciente, podemos hacerlo a través del índice de fragilidad y para eso son muy necesarias los test de calidad de vida. Y para evaluar la cirugía o el tipo de cirugía que vamos a hacer, podemos hacer con herramientas también tipo software que consiguen una mejor planificación de la cirugía y también calcular mediante índices, como también hacen en San Francisco, de agresividad de nuestra cirugía. Y todo eso lo podemos calibrar. Calibrando todo esto tenemos la estratificación del riesgo. Sabemos el riesgo que lleva el paciente para realizar el tipo de cirugía que necesitamos. Y una vez con todos estos datos, ya podemos dar el salto a la predicción de dos cosas, tanto de complicaciones como de resultados clínicos de la cirugía. Y eso sí que se tiene que hacer mediante inteligencia artificial. Hemos visto, y estos de los primeros trabajos que hicimos conjuntos, es cuál era el peso de las distintas variables sobre las complicaciones en este tipo de cirugía. Y hemos visto que más de la mitad se lo debemos a factores relacionados con el paciente y muchos de ellos son modificables. El 40% depende de la cirugía que le hagamos, sobre todo el sangrado de la cirugía, el tiempo que tardemos en operarles y si nos bajamos nuestra fijación a pelvis. Y solo un porcentaje muy pequeñito está transferido al cirujano. Esto nos llevamos sorpresas porque nosotros pensamos que los cirujanos de gran experiencia deberían de tener menos comorbilidad o menos complicaciones que los cirujanos de menor experiencia. Entonces, pasando punto por punto, lo primero es el índice de fragilidad. Sabemos que la fragilidad es un concepto sencillo, es la diferencia entre la edad cronológica del paciente y la edad fisiológica del paciente. Esto es lo que mide la fragilidad. Como bien ha presentado el doctor Ames, Emily Miller del grupo de la ISSG realizó este índice de fragilidad específico para deformidad de columna, cirugía de columna de deformidad, porque hay muchos índices que se utilizan en otras disciplinas. Este es específico para columna. Consta de 40 ítems, muchos de ellos son comorbilidades, otros son respuestas de los test de calidad de vida y dependiendo de cuántos ítems sean positivos, se hace una fracción sobre 40 y ahí sale un ratio. Si estamos por debajo de 0,3 seremos not frail, si estamos por debajo de 0,5 seremos severely frail. Para desarrollar este índice necesitamos, y esto es lo que yo le he preguntado al doctor, pasar los cuestionarios de salud a los pacientes en la consulta y esto lleva su tiempo. Nosotros pasamos estos 5 cuestionarios, que son el del dolor, el COMI-BAC, el OSWE-3, el ESRS-22 y el SF-36. Y con eso es como evaluamos cómo está nuestro paciente. Y hemos visto que también este índice de fragilidad por sí mismo es un factor independiente para complicaciones mayores. Es decir, los pacientes que tienen fragilidad grave tienen más índices de infección de la herida, más cifosis de unión proximal, más complicaciones y más reintervenciones. Volviendo al paciente, ¿qué hacemos ahora? Hacemos algo adicional. No solo miramos al paciente y escuchamos los problemas que tiene, sino los intentamos medir. Y los medimos con estas variables de todas estas escalas y medimos el índice de fragilidad con sus comorbilidades. Este es el paso que estamos haciendo más. Hemos visto a principios del año pasado estos 2 artículos que yo recomiendo, que son de enero en el Spine Deformity. Lo que miden es cuántos de los parámetros que tienen los pacientes son potencialmente modificables y con eso podríamos mejorar el estado de ese paciente. Al final lo que vamos a hacer lo que queremos es que nuestro paciente añoso corra una maratón, que es nuestra cirugía agresiva. Para correr una maratón nosotros nos preparamos de antemano. Así que a este paciente le podemos preparar de antemano para soportar mejor este tipo de cirugías. El cuadro que intentamos utilizar nosotros en el hospital esta guía está tomado del Cleveland y que se centra en 4 áreas muy específicas. La primera es mejorar el área médica, por ejemplo, el cese del tabaco, la nutrición o la mejoría de la sarcopenia con rehabilitación, mejorar el estado y la calidad del hueso, mejorar, y muy importante, la psicología del paciente, porque hemos visto que la ansiedad y el evitamiento al dolor produce peores resultados en los test de calidad de vida después de la cirugía. Y luego la selección del paciente. Estamos viendo que si al paciente se le opera con un poco de anticipación antes de que llegue a esa edad límite o a esa magnitud que nos obliga a hacer una cirugía muy agresiva, los resultados serán mayores. Y esto, en el contexto en el que yo trabajo en España, es lo que más difícil tenemos de implementar. Segundo sería la planificación quirúrgica y de la agresividad. Todos sabemos que empezamos a estudiar a los pacientes con radiografía, resonancia, escáner, test de flexibilidad y la visita física. Pero ahora lo que estamos haciendo con todos estos datos es meterlos dentro de una plataforma, de una database. Nosotros utilizamos el programa KEOPS, que consigue almacenar las imágenes, los test de calidad de vida y la cirugía que se le ha hecho al paciente, así como las complicaciones. Y con eso es con luego adelante utilizamos para hacer estudios, por ejemplo, de inteligencia artificial. Este programa también nos permite tener una imagen bien clara y con colores, que para nosotros es muy significativo, del estado del equilibrio sagital. Y vemos ahí con los distintos puntos. Lo que nosotros tenemos que intentar con nuestra cirugía es poner todos los puntos de los distintos parámetros dentro de la línea del corredor verde, porque sabemos que si nosotros dejamos un plano sagital posoperatorio adecuado, vamos a disminuir el riesgo de complicaciones mecánicas. Otra herramienta que utilizamos y que ha sido diseñada por el ESG y ESG es el Gap Score. El Gap Score, como saben, consta de 5 parámetros. El primero es la edad y el resto son parámetros lumbares, sobre todo retroversión pélvica, magnitud de la lordosis y distribución de esa lordosis. Y con eso podemos hacer una idea de cuál es el objetivo en nuestro paciente. Y también podemos servirnos de simuladores para un mismo paciente, intentar diseñar 3 cirugías distintas y ver cuál de ellas se adapta mejor al equilibrio que nosotros queremos conseguir. Pues volviendo a la paciente nuestra, aunque parece en la clínica que no tiene una extensión excesiva de caderas y una flexión de las rodillas y parece que está equilibrada, cuando echamos los números vemos que hay muchas variables que no están acorde y que no siguen el corredor verde, que tiene una retroversión de la pelvis y que tiene un desequilibrio anterior y una cifosis toracolumbar que hay que corregir. Y esto cuantifica cuánto es el grado de corrección que se necesita. Lo mismo hacemos con el GAP. En este paciente lo que nos está viendo es que todos los números los tenemos en rojo. Necesitamos mejorar la retroversión en 20 grados, mejorar la lordosis lumbar o la distribución de esa lordosis para poner al paciente en un plano ideal sagital. Otra herramienta que ha desarrollado el ESG es se llama ADSCI, que es Adult Deformity Surgery Complex Index, y esto lo que hace, muy similar al que utilizan en San Francisco, como nos ha comentado el doctor Ames, es calibrar la cantidad de cirugía, la agresividad o invasividad de nuestra cirugía, que está íntimamente relacionada con la pérdida de sangre y con el tiempo quirúrgico. Pues sabiendo todos estos conceptos antes de empezar nuestro viaje y estratificando los riesgos de nuestro paciente, sabemos qué puede ocurrir si desplazamos al paciente del punto A prequirúrgico al punto B, que es después de la cirugía. Y aquí es donde entra el Machine Learning. Lo que hemos hecho en los dos grupos es meter toda la base de datos, las 213 variables que recabamos de cada paciente. Esto se pasa por una máquina, la computadora entiende y desarrolla logaritmos para esto y nos da unos ciertos resultados. Cuanto más pacientes metemos en la batidora, más piensa el ordenador o la computadora y refina esos resultados preliminares, los va refinando con el tiempo. A este proceso de meter datos y refinar datos se le llama Machine Learning. Y esto es lo que hace el ordenador y es la base de la inteligencia artificial. Trabajando los dos grupos con Miquel Serra, que es nuestro estadístico del grupo, que es una fiera de persona, consiguió hacer esto, que son los clusters. ¿Y qué son clusters? Pues es dividir toda la muestra que tenemos en 3 grupos de pacientes que son muy similares entre sí y que tienen muchas condiciones similares. Aquí, como vemos, los 3 clusters que salieron de los 1.600 pacientes que metimos en el sistema fueron 3 grupos, el grupo joven y luego hay 2 grupos de mayor edad. Uno de cirugías primarias a la derecha y otro de cirugías de revisión. Y como vemos, esto se ve en la columna de la izquierda. ¿Qué más pudimos hacer? Pues hacer clústeres también de las cirugías y conseguimos definir 4 tipos de cirugías distintos de menos a más agresivo, cirugías sin osteotomías a cirugías con osteotomía o con osteotomías tricolumnares. Y lo que hacemos es distribuimos los clústeres aquí. Como ya teníamos la experiencia de qué ha pasado a 2 años con los pacientes y qué resultados clínicos tenían, es muy sencillo ver que, por ejemplo, los young coronals, si tú le haces una cirugía de tipo 2, el porcentaje de mejoría que va a haber en cada dominio de los cuestionarios es este. Y así sucesivamente con las distintas cirugías y las distintas opciones. Y por último, lo que hicimos es, con eso mismo, calcular el índice de complicaciones de cada tipo de paciente con un tipo determinado de cirugía. Esta tabla, que parece muy compleja, es la base del sistema de inteligencia artificial que utiliza nuestro programa para calcular qué va a pasar con un paciente dado. Es decir, si yo tengo un paciente nuevo que viene a la consulta, voy a meter todas las variables de este paciente dentro del programa. El programa va a ser capaz de reconocer aquellos pacientes muy similares al mío, tanto en características como en fragilidad, como en el tipo de cirugía que voy a hacer, y sabiendo qué ha ocurrido con esos pacientes de antemano, podemos hacer una predicción ficticia, claro está, de lo que le va a ocurrir a mi paciente en el futuro. A esto es lo que llamamos inteligencia artificial. Para desarrollar esa herramienta, otra vez se pusieron los 2 grupos juntos a pensar y sacaron este calculador. Este calculador está online, uno puede acceder a él y tiene 5 fases, como vemos aquí. Teniendo otra vez el paciente base, lo que hacemos en la primera fase es meter el perfil del paciente, edad, sexo, altura, etc. En el segundo estadio pondremos las comorbilidades, que las hemos tomado de antemano, hemos tomado esas variables y sabemos cuáles son. En el tercer estadio lo que hacemos es metemos los datos radiográficos que hemos introducido en la planificación quirúrgica y luego lo que hacemos es meter todos los cuestionarios de salud ítem por ítem dentro del sistema. Lo último que hacemos es planificar la cirugía que queremos hacer, de dónde a dónde vamos a ir, cuántos tornillos vamos a utilizar, va a ser un abordaje anterior o va a ser combinado, vamos a utilizar cajas, utilizaremos osteotomías o no. Una vez que tenemos todos los datos metidos, le damos al Enter, la máquina se pone a pensar, como hemos dicho, identifica aquellos pacientes con estas mismas características y predice que para mi paciente determinado que yo tengo delante de mí en la consulta, el índice de complicación que va a sufrir a los 3 días, 30 días, 60, 90 al año y a los 2 años. De tal manera que esta paciente que yo tengo delante, le puedo decir que a los 3 meses el índice de complicación que predecimos que va a tener es de un 34% y a los 2 años es de un 50%. Y es esta paciente la que puede ver si le compensa o no le compensa este tipo de cirugía. En este caso, de esta paciente tuvimos la PJK en el día 130 y estaba estimado que para el día 130 aproximadamente el índice de complicación y va a ser de alrededor de un 40%. También podemos hacer una predicción de las readmisiones y las reintervenciones de este paciente, de la misma manera. Y lo que es más interesante es podemos decirle con qué probabilidad va a mejorar en sus test de calidad de vida. Este es un ejemplo de esta misma paciente. Preoperatorio tenía un subtotal de 2,32 en el SRS-22 y mejoró a un 2,95. Nosotros habíamos vaticinado que tenía un 80 y algo por ciento de probabilidad de mejorar en este score y casi un 80% de mejorar por encima del MCID, que para este parámetro son 5 puntos. Es decir, que hicimos una buena estimación en este caso. Lo mismo puede hacer para el resto de dominios, tanto para el SF36 como para el ODI, como para el COMI. Lo puede hacer para todo. ¿Y de qué nos sirve esto? Pues cuando tenemos al paciente delante, esta predicción se puede imprimir y se le puede dar una hoja directamente al paciente diciendo, mire usted, tal y como está usted y con la cirugía que tengo que hacer, yo le voy a predecir que su curva de complicaciones va a ser esta. Y usted ahora se piensa si tomar la decisión de operarse o no operarse. Una cosa adicional que se le ocurrió al doctor Ames en todo este batiburrillo es, bueno, ¿y qué pasa con aquel paciente que está limítrofe entre dos grupos? ¿Qué va a hacer? Porque quizá es más diferente de estas personas y es más similar a estas otras. Entonces lo que consigue el programa es mirar los vecinos, los 100 vecinos que tienen alrededor más similares a su perfil, y lo que nos dice el programa es qué hicieron los cirujanos en esos 100 pacientes. Pues los cirujanos en ese tipo de pacientes tomaron la decisión de instrumentar DT2, instrumentar o no instrumentar la pelvis, hacer o no hacer osteotomías, y de esta manera podemos sugerir ciertas indicaciones para estos pacientes. Así como también predecir qué mejoría puede tener los test de calidad de vida. Y la cosa es cuáles son los future challenges, y tenemos 4. El primero de todos es intentar que esta herramienta sea lo más sencillo posible para que la gente la utilice. El segundo es probar que la percepción del cirujano no es mejor, no estima mejor este modelo que el ordenador. Por tercero, ver si esto es universal, si se puede utilizar cualquier tipo de cirujano. Y cuarto, y es en lo que estamos, esto solo tiene una predicción de un 70%, pero hay un 30% que se nos escapa. Y hay variables con las que no contamos. Para los dos primeros puntos, y estas son mis dos últimas diapositivas, ya tenemos una respuesta. Lo que hemos hecho es minimizar al máximo el número de variables que tenemos que meter por paciente, y si en un principio tenemos un proceso largo de 146 variables, ahora hemos conseguido disminuirlo en un proceso corto a 47 variables, de tal manera que sea más user-friendly. Y por último, y esto es un trabajo de este año, hemos permitido a los cirujanos predecir qué ocurre con determinados casos y a la máquina, y ponerlos en contra y a la máquina y cómo los predice. Y lo que hemos visto es que los cirujanos estiman en demasía las complicaciones del periodo posoperatorio temprano y, sin embargo, estiman muy mal, estiman por debajo los riesgos a los 90 días y a los 2 años. Bueno, esta ha sido mi charla. Si tienen alguna pregunta, estaré encantado. So, Chris, I'm done here. So, if there's any question that I can answer.
I have a question while I was listening to your presentations, and thank you so much, Dr. Pizones, as well. Great presentation also. Does ever happen to any of you that when you first saw the patient, you have a treatment in mind, and then the machine gives a completely different outcome?
I can respond to that. Essentially, we want to be very careful that the risk calculator and outcome calculator represents a shared decision-making tool. So it's not prescriptive, meaning it doesn't tell you what to do, at least at this point. So the surgeon may decide, for example, the most common scenario that we use is, should we do something very short and do something only from the back of the spine, or should we do an anterior-posterior procedure? We look at variation in where we stop the procedure. Sometimes we look at 1 versus 2, 3-column osteotomies, for example. And we weigh that very carefully as well with the alignment. But you know, the machine will often say there's no significant difference in outcome, but there's a significant difference in risk. And so that's how we use it. The other way I use it more commonly is in saying no. I find it very helpful when there's a patient that I don't feel like I can substantially help. For example, a middle-aged patient with a thoracic curve that has pain really in the thoracic spine. They've had that curve a long time. And I think maybe I can only really help their appearance. I don't think I'm going to be able to help very much their pain. And, you know, we'll look at what the machine says, and I can say, you know, I think this, and we ran it through the machine, and it gives us an instant second opinion on what your pain improvement is likely to be. And I find that very helpful, especially patients that come from far away. They don't think they're being shortchanged. They think they believe what the machine says, and it's kind of like an instant second opinion. What do you think, Dr. Pizones?
Yes. Of course, I agree with you. This is something that can help the surgeon make the decision and the patient too, because we don't estimate as good as the machine does. Actually, we underestimate the complication rate, and we, as Chris said before, it's very hard for us to tell the clinical improvement that the patients are going to have. So it's a really good tool for the clinic and to discuss the decision making with the patient.
Thank you. There is a question here. I guess will be for you, Dr. Pizones, because it came during the second presentation. It says, what program did you use to assess the balance?
To assess the balance is the KEOPS. This has been developed. KEOPS. It has been developed by Rousseau's son, and it's so you can approach him. It says you pay a fee every year, and then you get the tool. Not only measures that, but it's also the database that we use. So you can do both at the same time.
Okay, and that answer, they question if it was free. No, it's an annual fee. Okay, and they're asking for the link for the calculator, if it's possible to, I don't know. That's a question that is, I don't know if the calculator is free, it's open online. I have no information.
Currently, the calculators are only available in the groups. So the calculators are only available to ISSG, ESSG, probably very soon to the Asian group and the Latin American group. We want to beta test them and validate them again in broader, in a broader range of scenarios. And then once they're revalidated, we plan to open them up via the SRS most likely to general use by other surgeons. But our goal is obviously not to make any money off of these, but to provide them to as broad an audience as possible to improve the care of patients.
Exactly, as Dr. Pizones says, when more patients come in, you can get a more accurate, outcome from this IE process. So Thank you so much. Any further, if there's no any further questions that I don't see here online, I want to make a little pause just to say to all attendees that here is where to finish the presentation, but don't go out. While we were preparing this presentation for you, we realized that Dr. Ames and Dr. Pizones are on the northern hemisphere. So COVID hits there first, and they're on the other side of the curve. We're on the up curve, they're on the down curve. So if you want to stay a few more minutes, they're going to share with us how the spine surgery is recovering after COVID-19 and what it's been done different compared with the before COVID-19. So Dr. Pizones will be presenting something, and Dr. Ames will tell his part of the story.
Let me take a minute right here. Thank you, Boris. I'll be preparing a second. So this is just a 3-minute talk. So you know what we've done with the COVID pandemic. We started our first case in Spain. This is the satellite view of Spain, and you see that in Madrid and in Barcelona we've got the greatest cases, and because these are international cities having flights with international different sites. So our first positive patient in Spain was at the end of February. This is our curve that is almost done by now, thankfully. Last day of office was March 11th. And 2 days after that, everything stopped. We completely stopped. On March 20th, so 10 days after everything was stopped, we were assigned to the internal medicine department, helping those guys out because it was a huge amount of patients that came in. We reached our peak the beginning of April. We had in Madrid, is a 7 million population, and we had 16 admitted patients in the hospitals. In my hospital that we have in about 1,200 beds, we had 1,100 positive cases admitted. And our ICU, which has a capability of 60 or 70 beds, went up to almost 150 during that peak. So the measures we took is everybody had to go with cap, mask, gowns, and closed clogs. From our staff, we're 50 orthopedic surgeons there. They divided us in 4 segments, and every 15 days we had a shift into ER and wards with the internal medicine. And we just covered trauma and no surgeries, just trauma surgeries. This is the rehabilitation gym that we have in the hospital. Everything was taken away and reorganized as an ER. Actually, we had 60 seats and 20 more beds. And there is where we worked. So you could find our orthopedic surgeon with a neurologist and an ophthalmologist at the same time, looking for the patients. We went up to 1,100 admitted patients. And in Madrid, we built a military hospital for 3,500 beds. And we took a hotel next to our hospital where we used 200 beds for those patients that needed to be discharged, but they were not well enough to go back home. These are our operating rooms transformed into transitory ICUs, first with 2 beds and then with 3 beds. And this is almost the end of it. Beginning of last week, we began with telemedicine. We started surgeries, two more surgeries, 7 weeks after the stopped. We're beginning with the office this week. And instead of seeing 25 patients, we're seeing like around 7 or 8 patients every 30 minutes, so they can have time in between. Only one person can join these patients in the waiting room. And we're starting elective surgery this week and next week with easy cases. This is only Madrid. The blue line is the COVID positive patients. Gray line is the amount of deaths that we've had, and red line is the ICU inpatients. In total, for the whole Madrid, we have attended to, you see here the figure, very big figure of positive patients. And these are the ICU in admissions. We have to triple our ICU beds in Madrid. And to finish, we've had in our hospital over 800 deaths. In Madrid is 8,000 deaths, and in Spain is over 27,000. This is 12th of May, these figures. And deaths are, you can see in all ages, but actually beginning in the 40s and between 40 and 49, we had some deaths. And obviously the patients with older patients were more susceptible to die. Right now, we're starting ORs with pediatric cases, easy ones like casts or lengthenings. In adult, we're doing disc herniations and some tumors, but we're not doing any deformity. Patients with no comorbidities, only 2 or 3 days of hospitalization. And this is our protocol. So we do a swab test, PCR 48 hours before surgery, and we take x-rays or low dose CT. We take the test, leukocytes, ferritin D-dimer. If the patient is positive, we have to operate on him if it's an emergency with the PPEs. If it's elective, we have to wait a couple of weeks until, or 2 or 3 weeks until it gets negative. And if it's negative, we do a normal surgery but with double mask. We use FFP2 for surgery. And this is the experience that we've had, tremendous experience these 2 last months in Madrid.
Thank you, Dr. Pizones. Appreciate it. And thank you for sharing your experience. Dr. Ames, what was different in San Francisco? How's that? The curve is more or less like Madrid, still a little up on the down, or how is that?
You know, it's interesting. I think we're definitely not as hard hit in California, certainly in Northern California, as they were in Spain and certainly Italy. We have a little bit less population density up here, a little bit more area to spread out. So it's more of a sprawling metropolis rather than a concentrated city. So we thankfully haven't been as hard hit. We also had about a 2-month slowdown, but now we're ramping back up. We're almost at normal volume. So for example, this week, we've already done on my service three column osteotomies in adults that were elective. And, you know, we're increasing our volume all the time. And the hospital says we should be back to normal volume for elective cases on June 1st. So
Wow.
we're going pretty quickly back to, you know, full service, full volume. The one area that's been most, you know, educational to me in my own practice is we've been doing clinic visits the whole time using telehealth, and we've been triaging these patients, these deformity patients, using home visits with telehealth, and doing that via Zoom. Our patient satisfaction ratings have gone up about 20 points, 20 percentage points, by being able to visit with the patient in their house, and they don't have to drive and come in. Yeah. And we can actually evaluate them. We can do clinical pictures of them. The only thing we can't do is a neurological exam. But most of the deformity patients, you know, have normal neurological exam. And if not, and even if so, we can do a baseline exam just prior to surgery. So it's really changed our treatment paradigm. They get local x-rays, and we visit with them, and we're planning to do, moving forward, half of our adult deformity clinic visits using telehealth. And you know, it's totally changed that. So even after COVID, we're going to all telehealth, and we record the visit. We can transcribe the visit into text, all using programs, and we can even use AI to help us analyze the text of that patient visit, doing what's called sentiment analysis, where we can figure out, you know, is the patient depressed? Is the patient positive? How does the patient really feel? What is their education level? All sorts of things using AI-based text analysis. So, and plus we get a permanent document via video of that patient's visit. So wow. For us, it's been extremely, you know, educational in the use of telehealth, and I think we're never going back.
Yeah, definitely. Many things are going to change after COVID-19, and it's going to impact your practice. I'm sure of that.
Right.
A question for both of you that is a concern in the Latin America communities. What about the fear of patients of getting back to hospitals, fear of getting infected? What measures or campaigns or messages you give them just for them to feel safe, that they can have surgery and they won't be affected by COVID-19?
Let me take that one, Chris, if I can. So this is a big concern right now in Spain, because after 2 months of shutdown, they're doing studies on population to see how many of them are positive but being asymptomatic. And we thought that the rate was going to be like around 20%. But we have discovered that with all this shutdown is only 5% of the population which is positive. So I think that this strike is going to come back in the future, maybe not as bad, but is going to continue in peaks. So every 2 or 3 months, we're going to have a peak. And the big problem here is going to be financial right now because everything has been shut. So no bars, no restaurants, no shops, if we're going to have those peaks along the year, it's going to be very risky for our financial system. So we're trying to negotiate with people not to fear that go to the hospitals. First, starting by slowing and with clinics every 30 minutes. They'll get tested when they get in the hospital. They get the temperature. If the temperature is okay, they're given gloves and masks so they can go into the office. And they have 30 minutes with the surgeon. And once they're finished, you have to clean everything up with alcohol. And then the next patient comes in. But there's still a lot of patients that we call on phone and they don't want to come. Actually, Madrid is a very dangerous, is a zero zone for them. And many of them are delaying the offices for after the summer.
Great, thank you. That's all. Thank you so much. I don't know if you, Dr. Ames, have any further comments on COVID. Otherwise, we're gonna close.
No, I think that's great. The Spanish experience is much more interesting and in depth than what we've had in San Francisco so far. So hopefully,
unfortunately,
it'll stay that way.
Unfortunately,
yeah.
Yeah. So thank you so much. Very interesting and informative session that we have with both of you. We're gonna keep on working together to bring this knowledge to our region, to Latin America, and to make sure that more surgeons are aware that these innovations and innovative treatments are available and are ready to be incorporated into their practices. So thank you, both of you. Thank you all attendees for staying with us, for attending this webinar. In a couple of weeks, we're gonna have a new webinar that is cortical bones trajectory. That's gonna be on May 27. And as always, all of you are welcome to attend. Now, just thank you again, Dr. Pizones and Dr. Ames, for your time and for sharing your knowledge and your experiences with us. Good afternoon, everyone.